Hello students, welcome to today's class. I am Bernisha, lecturer from Emmanuel College of Pharmacy. Today we are going to discuss about an important topic from pharmacotherapeutics, that is inflammatory bowel disease. In this video, we are going to briefly discuss about the what is inflammatory bowel disease, their classifications, their etiology, pathogenesis, and their management. Come on, let's get into the video. First, let's see what is inflammatory bowel disease. Inflammatory bowel disease is a group of idiopathic, chronic, relapsing, and remitting inflammatory intestinal conditions. Inflammation is nothing but it means the intestines like small intestine or the large intestines or the digestive tracts fully gets inflamed. We know that the bowel means it denotes the digestive tract, so that when the digestive tract fully gets inflamed or some part of the digestive tract gets inflamed in inflammatory bowel disease. During these conditions, the body disturbs the ability to digest the food and absorbs the nutrition and also to eliminate the waste. So, based on the parts it gets affected, it is divided into two types or categorized into two categories, that is Crohn's disease and ulcerative colitis. So here first is ulcerative colitis. Ulcerative colitis means it is mainly limited to the large intestine and the rectum. Here mainly the inflammation occurs on the large intestine and the rectum. Here inflammation mainly occurs on the innermost layer of the lining of the intestine. Mainly in ulcerative colitis, the inflammation begins from the rectum and lower column, but it can spread continuously to involve the entire column. So, when the ulcerative colitis is not treated in the beginning, it may spread and it affects the entire colon. This is the structure of the mm, colon. First, when it is starts from the area, then ascending colon, then transverse colon, descending colon, and rectum. So last part is the rectum. When the rectum gets affected by this inflammations, it gets further passed to the descending colon, then moves to the transverse colon and ascending colon. So that the whole colon gets affected by the inflammation. Here, so ulcerative colitis means the inflammation occurs only in the large intestines along with some of the lesions or bruises like we have seen on the ulcers. So next one is the Crohn's disease. Crohn's disease is also the inflammation. Mainly it affects any part of the GI tract. We know that the GI tract means it starts from the mouth to the anus. So it may affect any part. Like it may also affect the esophagus or the small intestine, and also the large intestines. But mainly this Crohn's disease affects the small intestines, the ileum, where it joins the beginning of the large intestines like colon. So, mm, though it affects any part of the gastrointestinal tract, the main part of affection is the ileum. So, ileum is the connective part of the large intestine and the small intestines. Here, the Crohn's disease appears like patches and it affects in some areas of the GI tract while leaving other secretions completely untouched. So, it cannot continued or it is not like communicable. So, once some part is affected, that only part gets affected till the end. It won't spread from one place to another. So this is the picture which shows the difference between the Crohn's disease and the ulcerative colitis. Here we can see that only the certain part, not a continuous part, the certain part like some ileum part, and also some part of the descending colon. So we can see that it is skip lessons. So some of the main parts only gets affected in Crohn's disease, but in ulcerative colitis, the continuous chronic involvement. It means when the inflammation is beginning from the rectum, it continues to the descending colon, then it reaches the transverse colon, then it fully covers to ascending colon. So it is a continuous chronic involvement. Crohn's disease is like skip lessons, and ulcerative colitis is like the continuous chronic involvement. Mainly it's beginning from the rectum. Next one is its epidemiology. Epidemiology means mainly the peak age. What will be the age for the ulcerative colitis and Crohn's disease is between 15 to 30 years. Moreover, the people with 15 to 30 years gets affected with this ulcerative colitis and Crohn's disease. Here, the second peak occurs between the age of 60 to 80. Mainly in male to female ratio, it is about 1:1 for ulcerative colitis, and for Crohn's disease, it is 1:1 to 1:8. So sometimes the female gets easily affected than the male for the Crohn's disease. The risk of ulcerative colitis in smokers is 4% than that of the 40% than that of the non-smokers. So the persons who smokes can be easily affected than that of the non-smokers. And the patients have inflammatory bowel disease. The lifetime risk with the first degree relative with affected is 10%. So mainly it is affected in the years between 15 to 30 years. The second peak occurs between 60 to 80 years, and the ratio is along with 1:1 or 1:8, and mostly the females are affected by Crohn's disease more easily than the ulcerative colitis. Here, the non-smokers, the smokers have 40% higher risk than the non-smokers for affecting of this ulcerative colitis and Crohn's disease. This is the etiology. Etiology means causes. How this? What are the reasons for the inflammation of this digestive tract? First one is genetic predisposition. So it is like genetic conditions, so that the genes may travel through families. If the parents or their grandparents are affected by such diseases, it may transfer to their children through genes. So it is a genetic predisposition disease. Next one is mucosal immune system. Sometimes this Crohn's disease and the ulcerative colitis are defined as the autoimmune disease, so that the bacteria gets affected the intestine, and um, it also triggers the um, good cells. It also triggers the good cells also get attacked by the body's immune systems, so that moreover the intestine gets fully affected. So it is an autoimmune disease or immunoregulatory defect. And the environmental triggers like luminal bacteria infections and the continuous use of NSAIDs, that is the non-steroidal anti-inflammatory drugs, along with the smoking habits. We have already studied that the smoking habits have moreover 40% uh, high risk than the non-smokers. These are some of the causes of inflammatory bowel disease. First one is genetics, that is the receptors when it gets affected easily. The next one is immunology, then that is mainly due to impaired epithelial barrier functions and body regulations, and overreactive response to autophagy. And it overreactive response means when there is a foreign particles get enters into the body, the immune cells attacks the foreign particles along with the good cells. So it may be the overreactive response to autophagy. The next one is environment like diet, smoking, antibiotics, and latitude may also causes the reason for the causes of this inflammatory bowel disease. And the next one is microbiome. Microbiome means some of the bacteria like Enterobacteriaceae, Bacillus, Velinolacea, Fusobacteriaceae, Erysipetrolysis, Bacteroideals, and Clostridiales. So these are some of the bacteria which is the reason for the inflammatory bowel disease. So the next one is diet. Diet means the fat intake, fast food. Most of the diseases are due to the intake of the fast food and less fiber consumptions. The next one is infections. Mainly the Crohn's disease is due to Mycobacterium paratuberculosis bacteria, and ulcerative colitis is due to episodes of infective diarrhea. Next one is enteric microflora. The intestinal microbiota, which is dominated by the bacteria, but it also sometimes includes as the virus, fungi, and protozoa is crucial for the development of the host immune system, but it also appears to be the target of the inflammatory response during the inflammatory bowel disease. This composition of the intestinal microbiota appears to be the altered during the disease. Next one is genetics. It is due to the linkage of human lymphocyte antibody like IL-1 ORA and IL-1 ORB. Next one is the first degree relatives are more prone, so that when there is a marriage between the first degree relatives, it may the children may more prone to this inflammatory bowel disease, and it will be greater in the monozygotic twins. When we are seen it on the antibiotics, the precipitate relapse of disease due to the change in the enteric microflora. Next one is cigarette smoking. We have already studied that the smokers are 40% as likely as non-smokers to develop the ulcerative colitis. Active smokers are half as they like to be hospitalized as non-smokers, and the former smokers are 50% and more likely to be hospitalized, and twice as likely as current smokers or those who have never smoked to require colectomy. Next one is appendectomy. That is, it is the protective effect of nearly 70% of the appendectomy for the development of ulcerative colitis. Patients who developed ulcerative colitis after appendectomy were less likely to develop recurrent diseases than those with colitis. Appendectomy means the removal of appendix. So next one is stress. Stress also sometimes triggers the relapse in inflammatory bowel disease by activating inflammatory mediators at enteric nerve endings in the gut valve. So these are the location for ulcerative colitis. Proctitis means in these conditions only the rectum gets inflamed. All the other colon parts are not remains untouched. So here only the rectum is inflamed. Next one is proctosigmoiditis. Along with the rectum, the sigmoid or colon also gets inflamed. So it is known as proctosigmoiditis. Along with rectum, the sigmoid colon also gets inflamed. Next one is distal colitis. In this, the descending colon along with the sigmoid colon, all the rectum gets inflamed. That is known as distal colitis or descending colon colitis. Next one is pancolitis. Pancolitis means the entire colon gets inflamed. The entire colon means the full part of the large intestine gets inflamed. Next one is the backwards ileotis. Ileotis means only the appendix gets inflamed. After the appendectomy, first the appendix gets inflamed. That is known as backwards ileotis. Backwards ileotis. Next is the pathophysiology. Here, first, what happened means the triggering events. First, the dysregulator inflammatory and immune response in the genetically susceptible persons. First, it is the dysregulator inflammatory and immune response. And next, it is the amplification of the immune response so that it may release of inflammatory mediators like release of TNF alpha pro-inflammatory interleukins. After that, it is the mucus breakdown and continuous exposure to human dietary or bacterial antigens. After that, impaired handling of the microbial antigens by the immune system and thus causes the inflammations. After the inflammatory mediators get dysregulated or amplified, it releases the inflammatory mediators and continuous exposure to the human or bacterial antigens. It may lead to the inflammation. Next one is symptoms. The altered bowel movements or increased stool frequency or decreased stool consistency. Mainly there will be the altered bowel movements, then abdominal pains like LLQ cramping, relieved with defecations. There will be like cramping before defecation and after the defecation the cramping gets relieved. Next one is tenesmus. Next one is hematochezia. Hematochezia means nothing but it has blood in stool. Next one is Crohn's disease. Crohn's disease has also have altered bowel movements and mostly there will be the chronic or nocturnal diarrhea. After that, abdominal pain means it also shows postprandial, oral Q, abdominal pain and distensions. Moreover, it has chronic diarrhea. It may also show weight loss and fever. So LLQ means left lower quadrant. In this picture, we can see the LLQ. So in ulcerative colitis, mainly there will be the left um, quadrant, left lower quadrant cramping. In for Crohn's disease, there will be the right lower quadrant more pain. So these are some of the difference between the symptoms in ulcerative colitis and Crohn's disease. Here mainly as the lining of the intestine becomes inflamed and ulcerated, it loses its ability to adequately process food and waste or absorb water, resulting in loose stools, that is the diarrhea, and in severe cases it may also lead to weight loss. Inflammation can cause also small sores like ulcers to form in the colon and rectum. These can join together and become the large ulcers that bleeds, resulting in bloody stools. So blood loss can also eventually lead to anemia if unchecked. So these are some of the explanations for the weight loss and the bloody stools, how the weight loss occurs and the bloody stools occurs. Next is management. Management means how we are going to manage this inflammatory bowel disease. First, we have to improve and maintain patients' general well-being. And first, we have to treat the acute disease, that to eliminate the symptoms and minimize the side effects and long-term adverse effects. We have to eliminate the symptoms, minimize the side effects and the long-term adverse effects. It will also reduces the intestinal inflammation and if possible we have to heal the mucosa. We have to prevent the complication, hospitalization and also the surgery and to maintain the good nutritional status. These are the goal of our treatment to treat IBD. So mainly we have to maintain the patient's general well-being. And the next one is pharmacological management. First one is the aminosalicylates. So mainly the anti-inflammatory agents like 5-aminosalicylic acid, mesalazines and sulfasalazines are the some of the aminosalicylates drugs which are mostly prescribed for this inflammatory bowel disease. And the next one is immune modifiers. Immune modifiers means to improve the uh, immune system of our body, we have to take thiopurines like azathioprine, mercaptopurine, along with the calcium urine inhibitors such as cyclosporine and tacrolimus, along with methotrexate. Next is antibiotics. To treat the bacterial infections, we have to take metronidazole and ciprofloxacin. Next one is corticosteroids. Corticosteroids are mainly used to treat the inflammations, mainly intravenous. In intravenously, we are taking methylprednisones and hydrocortisons. In oral, we are taking prednisones, prednisolones, and dexamethasones. These are mainly taken to treat the inflammation. The next one is biologics. These are used to treat the necrosis, that is infliximab, adalimumab, and certolizumab. Adhesion molecule antagonists like godelimumab. Next is probiotics like VSL SHAS3. So these are some of the medicines we are taken prescribed during the pharmacological management of IBD. So the pharmacological management means the management using the medicines or drugs. So these are some of the drugs which is used to treat the inflammatory bowel disease. So next is also the inflammatory bowel disease. What are the drugs we are given? One is cellular therapy, corticosteroids, antibiotics, aminosalicylates, thiopurines, biological therapies, and folic acids and conus. It is used to reduce that anti-inflammatory effects. So these are the flowchart which just shows the pharmacological management of the drugs which is used to treat the inflammatory bowel disease. And the next one is for the symptomatic therapy and supplements. We know what are the symptoms, mainly diarrhea. So we have to give anti-diarrheal such as loperamide. That is, we have one. So, antidiarrheal is given to the normal people if the colitis is what are the conditions if the colitis is not fulminant and cholestyramine, and we have to give cholestyramine if the patient has previously undergone ileal resections. For normal things, we have to give loperamide, and if a patient has undergone ileal resection, we have to give cholestyramine. And the next one is analgesics like painkillers. So we have to give such as acetaminophen or even codeine. If acetaminophen is insufficient, we can give codeine. And the next one is nutritional supplementation. Nutritional supplementation for those with malnutrition or during periods of reduced oral intake. If a patient is under bowel rest, we have to give the nutritional supplements through IV route. If patient has lost the ability to absorb the nutrition and also to take the food intake, so we have to take the nutritional supplementation. And the next one is vitamin B12. This is used to take for the iron deficiency. And the next one is vitamin D supplementation. If the local area does not allow sun exposure for much of the year, and the patients on thiopurines who are using the sunscreens. Protein, vitamin D, and calcium supplementation for corticosteroids users. If we are taking corticosteroids, we have to check whether we are taking full calcium supplementation along with the vitamin D. Next one is routine multivitamin supplementation for all. We have to take the multivitamin supplementation so that we can reduce the nutritional deficiencies. And for chronic iron deficiency anemia and parenteral iron should be administered either as weekly intramuscular shots or dosing with intravenous ions if oral iron is not tolerated. So these are some of the symptomatic therapies which is used to treat the symptoms that is seen during the inflammatory bowel disease. So in this video we have learned about what is inflammatory bowel disease along with their types like ulcerative colitis and Crohn's disease. In Crohn's disease we have seen that the whole part like a single parts in the digestive tract gets inflamed. In ulcerative colitis, it's like the continuous movement of inflammations from moreover from the rectum to descending colon. And the next one is etiology, how it may causes like genetic predispositions along with autoimmune disorders and also the environmental triggers like smoking, diet, etc. And the next one is its pathogenesis. We know how it gets um, how the body gets easily affected by the Crohn's disease and ulcerative colitis from inflammations. And the next one is their management. That is from non-pharmacological management or non-pharmacological management. So pharmacological management, what are the drugs like aminosalicylates, biologics, corticosteroids, like some of the drugs which we have used to treat this inflammatory bowel disease. Along with next is symptomatic therapy, like what are the drugs which is used to treat the symptoms. So these are the descriptions of full detailed description about the inflammatory bowel disease. Mm, Students, I hope you all have learned about some informations for the inflammatory bowel disease, Crohn's disease, and ulcerative colitis. I hope this video will be very helpful for you to learn about this inflammatory bowel disease. Let's see in the next video in a new disease. Thank you.